So moving on from one unusual person to another person who always is a daredevil surgeon, Dr. Saravanan, management of post-surgical macular displacement and macular folds. Over to you.
Thank you, Sunakshi madam. Post-surgical macular folds are a very, very unusual complications. I personally operated only 2 cases, so I don't have videos. I have borrowed the video from Dr. Naresh. And some of the precipitating reasons why this can happen is a superior bullous RD where the macula is just involved, and a fresh RD because of the very fast RP pump. When the retina attaches very fast, it can lead to redundant retina, which can form a fold over the macula. This has been described following vitrectomy, pneumatic retinopexy, as well as scleral buckling. The problem is that it can lead to defectivation, metamorphosia, diplopia, and also sometimes visual field defect. So if it's a peripheral fold, you can leave it, if it's not disturbing the 4 VR macula, you can leave it. It's not going to cause any complication. But if it's threatening it's involved in the 4 VR, it's going to lead to inner layer atrophy and photoreceptor loss if it is left like that for a long period of time. So I told you the risk factors include superior bullous RD where the 4 VRs split or just involved, and giant retinal tear and giant retinal dialysis which has not been managed properly, intraoperatively, where there's retinal slippage. And when there's a large amount of leftover SRF, this can sometimes cause this bullousness to sort of drag down the retina and cause the fold. And if you're doing a pneumatic retinopexy, a large intraoperative injection of gas bubble, and also improper positioning. Normally you have to do the steamroller technique. If you're not doing a steamroller technique and directly going for erect posture in a superior RD with a superior bullous RD, this can lead to a macular fold. And also when you're doing a scleral buckling, when you have very tight buckle or a very high buckle height, it can lead to a redundant retina, which can lead to a whole fold formation over the macula. So various techniques have been described to correct this, and this is one article by Xavier et al. Where they showed 2 different techniques where the retinal fold is very big and very prominent over the macula. So they felt that inducing a retinal detachment by injecting BSS under the retina, doing a retinectomy to reduce the redundancy of the retina, and then injecting PFCL to flatten the fold, thereby enabling to PFCL to iron out the fold as you inject. That's what they did for very large or very thick macular folds by doing a retinectomy to release the redundancy. So in a smaller fold, like in this case, they said that it's not necessary to do all this. So just inject BSS to sort of mobilize the retina and use a little bit of PFCL and sort of a small increasing the BSS by injecting a little bit more, and sort of a juggle technique, try to inject BSS and more PFCL alternatively, thereby pushing the fluid towards the mid-periphery where it can be aspirated by you doing a retinotomy, and which can be barrage. This is the results of that technique. For small holes, we can just get away by doing injecting the BSS under retina and using PFCL to iron out the fold. For a large, you may want to do a reduce redundancy by doing either a imbrication or a relaxing retinectomy. There's one more report where they did with just air. Here they didn't use any PFCL. They just induced RD by injecting BSS under the retina and injected gas, and with postoperative positioning only, they were able to iron out the fold without the need for using intraoperative PFCL. This is a video showing the management of macular fold. You can see here this is the Med1 needle, which is used to inject the BSS, which is routinely used for macular translocation surgery and all those techniques which already you've seen in the previous videos. So you're injecting BSS under the retina to cause an RD, and then trying to inject air to sort of fuse these so that you can get a more free retina, so where the retinal fold can be flattened by using PFCL. So once the retina is mobile and you feel that it is free enough, then you can inject PFCL to sort of iron out the fold. And PFCL has a better efficacy when injected under BSS rather than under air. So this has got a better ironing effect when you are injecting under BSS. And you can do a concomitant ILM peeling or retinal massage by using a Thanos or by a finesse loop in case you feel that the retina is not getting fully ironed out. So you're trying to flatten the retina now. And then now we move on to the ILM peeling. So peeling the ILM also has a sort of massage effect, so that when you peel it in the opposite orientation of the fold, this helps you to sort of iron out the fold also. So this is the end of surgery and the additional laser. And this is the post-operative picture where showing the that the fold is ironed out now. And this is one more case where you can see the preoperative OCT and the post-operative OCT, where you can see the fold has been ironed out nicely. So the tips to avoid fold is that you have to minimize the amount of posterior fluid, especially in large superior bullous retinal detachment. And also you can try to employ measures like enlarging the small breaks, utilizing perfluorocarbon, or a posterior retinotomy for clearing of residual submacular fluid, and also performing a slow and complete fluid exchange. And also proper face down positioning also will help you to prevent this superior retina dragging down because of the superior gas tamponade. So this also helps to prevent the avoid the postoperative macular hold formation. Next to macular displacement, what we routinely see is a very, very mild displacement when you have a successful reattachment surgery. This does not cause any residual vision loss, but it can cause metamorphosia and distortion, which slowly gets ironed out over a period of 1 to 3 years. So this is the most common seen in vitrectomy, second less common in scleral buckling, and the least common in pneumatic retinopexy. But this is not what we are talking about. We are mainly talking about the ectopia, where there is considerable dragging of the fovea and macula. It can be what you can term it as a fovea or a macular ectopia. I feel the most common cause for such ectopia is consider a very significant PVR formation in the postoperative period, which can drag the fovea in any direction. So here you can mainly do the peeling of the PVR, and most of the times it will come back to a near normal anatomy. And also sometimes the leftover contraction of the leftover skytic posterior vitreous, especially in high myopia and syndromic arteries, can also contract and cause significant macular ectopia. And also intraoperatively, when you are not dealing with the large giant retinal tear or 360 giant retinal tear, where there is unintentional translocation of the fovea. Just to showing you two small videos of the to tell you how a transparent skytic vitreous is there. You can see I am trying to peel a ileum in a myopic macular hole, but here you can see that there is a leftover hyaloid there which is now disturbing. So it's so transparent that easily missed. Unless you look for it, you can miss this, and sometimes this can contract on the postoperative period causing foveal ectopia. There is one more case in a high myopic patient where you can see there's a re-RD with subretinal oil, but this was mainly traction created by the presence of residual hyaloid. So we didn't first realize that, but you can see now as I'm trying to peel this peripheral PVR, you can see that the leftover hyaloid is intact throughout the inferior pole, and this was the cause for the main detachment. Also there was some dragging of the fovea towards that area of traction. So it's a total leftover sheet from the leftover skytic hyaloid which has just contracted. So in case you have a significant macular dislocation, inject a small PFCL over the postoperative just to cover the macula, and using two instruments like a Thanos or a Finesse loop, you can just rotate it. If you inject too much of PFCL, the retina will not move around. So just inject just enough to cover the posterior pole, and then you can massage the retina to its original position. If it's only a small, you can just do a temporal retinectomy and then do this, or also you can do a scleral imbrication to clear the redundancy and then do this under PFCL. Thank you.
Thank you, Dr. Saravanan, for putting us through how to tackle the macular folds and the macular displacement.